Hello and welcome to part 2 of clinical cases for the endocrine system. Today we're going to be taking a look at some more conditions that have got links to the endocrine system. These include obesity, the microvascular and macrovascular complications of diabetes, Cushing's syndrome and disease, Addison's, and tall and short stature. So to start with, let's take a look at obesity, which is an accumulation of body fat with detrimental effects on health. It's really important to be aware of the epidemiology because around 2.8 million people die each year as a result of being overweight or obese, and the prevalence of obesity has nearly doubled in the past 20 years. It leads to a large number of complications, whether these be mechanical, metabolic or psychological, inclusive of things such as type 2 diabetes, vascular diseases, depression, low income, and there's also a link to infertility and polycystic ovary syndrome as well. As clinicians, we tend to look at the BMI, and we calculate this by taking the weight of the patient divided by the height squared. And it's essentially the body mass index. It's a way of taking a look at someone's weight, but taking into account how tall they are as well, because of course a taller person is going to weigh more naturally than a really short person. So it gives you a more accurate picture, clinical picture of the patient. So in terms of interpreting the BMI results, so anything below 18 indicates the patient's underweight, 18 to 25 is a healthy normal weight, 25 to 30 is overweight, and then above 30 is obese, and you can class anyone with a BMI of above 40 as severely obese. We can take a look at hormones, neurons, and the hypothalamus in their role in obesity. So for example, in terms of hormones, ghrelin is a hormone released both by the stomach and the brain, and it makes you hungry. So therefore we release this when our glucose levels fall. Leptin, a deficiency here would lead to increased and uncontrolled desires to eat. So this is a little bit of the pathophysiology, if you wish, behind obesity. In terms of neurons, you've got neuropeptide Y and AGRP, and these stimulate feeding and inhibit satiety. Or we have POMC and CART, and these stimulate satiety and inhibit feeding. So for example, a mutation in the POMC would as a result lead to uncontrolled eating as well, just like a deficiency in leptin. The hypothalamus also plays a role. So for example, the lateral hypothalamus is responsible as our feeding centre, and the ventromedial nucleus of the hypothalamus is responsible as our satiety centre. There is a link to a syndrome of obesity. So the commonest genetic syndrome of obesity is Prader-Willi syndrome, and this is a defect in chromosome 15. They tend to have poor feeding until around 2 years old. They seem to be behind, and then all of a sudden they get a ravenous appetite from there onwards. With regards to management of obesity, it's important to think about what the individual can do themselves with regards to dietary changes and physical exercise. In addition to that, some medications, but few do work. Orlistat is the only one on the NHS which we can use, and it even still is not that effective in all patients. And surgery in more severe cases, for example those that are severely obese and unable to lose a large portion of weight, bariatric surgery, whether that be sleeve, Roux-en-Y or laparoscopic, can help patients as well lose weight. Now I'm going to take a look at the microvascular complications of diabetes now. These are retinopathy, neuropathy and nephropathy. So diabetic retinopathy is a condition which damages the retina due to having diabetes mellitus, and it is actually the leading cause of blindness. So the longer a person has diabetes, this increases their risk of developing diabetic retinopathy significantly. And it actually affects 80% of people who've had diabetes for 20 years or more, so it's a really common complication. In the early stages, there are very few symptoms of it, is what makes it quite hard to determine this is happening, but as it progresses, the patient will start to experience spots or dark strings floating in the visual field, associated with blurred vision as well, fluctuating vision and impaired coloured vision. But all of this essentially will lead to visual loss. It is having a retinopathy is the leading cause of blindness. So the reason behind why this happens, the hyperglycemia that you sustain in diabetes leads to a blockage of the tiny blood vessels that nourish our retina, and as a result this cuts off the blood supply to the retina. As a result, the eye tries to compensate and grow new blood vessels, but these don't develop as properly as they should, and as a result can leak very easily, leading to hemorrhages within the eye. Now, the risk factors for this, essentially anyone of course who has diabetes, but actually it's the duration of diabetes which is important. It is usually those that have had it for more than 20 years developing diabetic retinopathy. There are two different types as well. You could have early diabetic retinopathy. This is more common, and this is where your new blood vessels are not growing, so your retina is not getting enough nourishment, and this causes microaneurysms. And then there's advanced diabetic retinopathy. This is more severe, less common, and it causes scar tissue and retinal detachment as well. So diabetic neuropathy now, so this is a nerve damaging disorder associated with diabetes mellitus, again a microvascular complication. And it's as a result of the injury to the vasa nervorum, so these are the small blood vessels that supply our nerves. As a result, there's a massive widespread effect, and it normally affects peripheral nerves, so those sensory motor neurons, and it rarely affects the autonomic nervous system, so it rarely affects our parasympathetic and sympathetic nervous system. As a result, neuropathy can affect all organs and systems, because pretty much all of our organs and systems have some form of peripheral nerve supply. Now, in terms of signs and symptoms, it can vary, of course, depending on which nerve is affected, but it can lead to things such as difficulty to balance, numbness, tingling of the extremities, and dysphagia. What's really important is it affects those peripheral limbs first, so it's affecting the hands, the feet, and upwards, and it works its way centrally. The incidence of this is quite common in the overweight patients, particularly those with poor control over their diabetes. A diabetic person with good control is less likely to develop a complication. So diabetic nephropathy now, so this is a chronic loss of kidney function occurring in those with diabetes, and it is very slowly progressive. It's very much linked to CKD, this, so if you understand the concept of CKD, you can kind of understand this as well. So diabetic nephropathy is as a result of multiple metabolic changes that diabetes causes within the body, leading to a release of excess reactive oxygen species. Now, these excess reactive oxygen species cause damage to the kidneys, so they can constrict the efferent arteriole and dilate the afferent arteriole. As a result, this causes capillary hypertension and hyperfiltration, so the kidneys are filtering more blood than they can cope with, and over time the kidney can no longer cope with this high demand, and then hypofiltration occurs, so underfiltration, not enough, and as a result we have changes in the glomerulus. So for example, the basement membrane thickens, the podocyte slits become larger, and as a result we see things like proteinuria, so protein in the urine, low serum albumin as well, because it's all being excreted in the urine as well. Just a little word on macrovascular complications now. So macrovascular complications, just down at the bottom here, this affects the large blood vessels in the body. So retinopathy, neuropathy and nephropathy are all about the smaller blood vessels, the capillaries. Macrovascular complications affect those larger blood vessels, and essentially it can lead to things such as cardiovascular disease, hypertension and peripheral vascular disease. To zone in on three large vessels that are important: for example, with the brain you have an increased risk of stroke, increased risk of TIAs, so transient ischemic attacks, and cognitive impairment. With the heart, it can lead to high blood pressure, it can lead to insulin resistance, can increase the risk of coronary heart disease as well. There are correlations there. And with regards to the extremities, these blood vessels can be narrowed, and this can reduce blood flow to the legs or to the hands. And as a result, we tend to see feet wounds. So what this really is talking about is diabetic foot. And this essentially is a foot pathology, so infection, ulcer, or osteoarthropathy, as a result of the diabetes. So we can prevent this by having a good control over the diabetes, regulating those glucose levels within the norm, and we can treat it with systemic antibiotics. But really this does depend on the severity of the infection that the patient's got, and amputation is sometimes an option if it really is severe. So foot ulcers can affect both type 1 and type 2 diabetics, and it's as a result of the reduced nerve functioning, leading to peripheral neuropathy. As a result, the nerves normally carry pain sensation to the brain from the feet. So for example, if you've got an ulcer, you would try to avoid walking on that ulcer to make it less painful, but these people cannot feel this pain sensation, and as a result they continue to walk on it, and as a result it gets bigger and bigger and more serious, and as a result leads to this kind of diabetic foot. It's a very much umbrella term for a variety of pathologies associated with the complications of diabetes. Next we have Cushing syndrome. So it's really important to differentiate between Cushing's disease and Cushing syndrome. So Cushing syndrome refers to the collection of signs and symptoms as a result of that high cortisol levels. On the other hand, Cushing's disease is all about the pituitary. So for example, you have a pituitary adenoma which causes an increased release of ACTH. In this case, this is Cushing's disease because we're indicating there's a problem with the pituitary gland, and not with the actual adrenal gland themselves in the zona fasciculata. So cortisol, Cushing's disease, refers to a problem higher up in the pituitary, whereas Cushing's syndrome refers to the collection of symptoms which is seen as a result of high cortisol. So there are several causes of Cushing's syndrome, and they can be exogenous. So, for example, taking an oral corticosteroid medication in high doses for a long time. So, for example, prednisolone. Endogenous as well. So, the body produces too much cortisol. So, this can be an adrenal pathology, as we've just said, or it can be a pathology higher up leading to excess ACTH. So, for example, a pituitary adenoma. And then we can have endogenous causes as well, so things such as an ectopic ACTH secreting tumour, a tumour somewhere else in the body that's releasing ACTH. The symptoms are slightly different in women and men, so in women you'd expect to see thicker body and facial hair, and irregular menstrual periods as well. In terms of men, you'd expect to see decreased libido, decreased fertility, and erectile dysfunction, so all those symptoms are fairly well linked in. With regards to treatment, it can usually take a long time to get this under control, but when you do get it under control, it does normally improve, and it really does depend on the cause as to how we go about treating it. So next to consider is Addison's disease, and this is the opposite essentially of Cushing's, because it's where the adrenal glands produce too little cortisol or insufficient levels of aldosterone as well. So normally cortisol and aldosterone in this case go hand in hand. We have low levels of both. And this can affect all age groups and both sexes, and it can be life-threatening as well. It's also important to be aware of something called an Addisonian crisis, and this is an untreated Addison's disease, which leads to a absolute massive attack of lower back pain or abdomen pain, severe DMV leading to dehydration, low blood pressure, floating in and out of consciousness, and hyperkalemia and hyponatremia as well. But basically, Addison's disease is those low levels of aldosterone, low levels of cortisol in the body. And the symptoms do develop slowly over a period of months, given it's normal Addison's disease. And these symptoms include things like extreme fatigue, weight loss, decreased appetite, hypotension, and hypoglycemia. So the causes behind this, again, it could be a damage to the adrenal glands themselves, leading to insufficient production of the hormones necessary. And when we think about these kind of diseases, we can think about a primary or a secondary problem. So primary problems are those actually to do with the adrenal glands, so damage to the cortex itself, such as an autoimmune condition. There's also links to TB with this as well, infections, spread of cancer to the adrenal glands. But then we can think about secondary causes, and these are ones that come from higher up, so problems with the pituitary or the hypothalamus, for example. Also, we can link this into patients that take corticosteroids, so these are anti-inflammatory meds, and suddenly stop taking them, they can develop Addison's disease, and this is classed as a secondary cause as well. Of course, it's important to be aware of the normal actions of cortisol and the normal actions of aldosterone, because in conditions like these, essentially, you're going to end up with symptoms opposite to this. So, for example, if cortisol helps regulate blood pressure and the cardiovascular system, a lack of cortisol means we're going to have hypotension, for example, and this is seen within the symptoms just here. So you can kind of link in their normal actions, and if they're not happening, what's actually going to happen to the body. Lastly, for this video, just take a look at short and tall stature. So short stature is where your height is less than 2 standard deviations below the mean for your age and sex, and potentially any condition that you may have. So there are several different types of growth charts that you can use, and it's important you're using the right one for the right patient. Likewise, tall stature is where your height is more than 2 standard deviations above the mean for your age, sex, or condition. The most common cause of referral is short stature as opposed to large stature, and you'd want to do a variety of investigations to see why this is happening. Things that can contribute to having small stature, this may be nurture, so for example how you're brought up, familial, delayed puberty, or simply a small gestational age where you've not caught up. The pathology behind it might be a growth hormone deficiency, Turner's syndrome, Prader-Willi as we mentioned earlier, a chronic renal insufficiency, and again SGA babies with poor catch-up growth. And again, we're always looking at treating the underlying cause. With regards to tall stature, the causes are fairly similar, so familial or simple obesity as well is really important. In terms of syndromes, Marfan's, Klinefelter's, and homocystinuria can all cause tall stature, as well as Fragile X, Soto's, and Beckwith-Weidman. The endocrine pathology here, so sexual precocity, thyrotoxicosis, growth hormone excess, aromatase deficiency, and estrogen receptor defects, all can cause tall stature. And the treatment tends to be focused around sex steroid therapy and somatostatin analogues. That's everything for this video. I hope you found it useful, and if you do have any feedback, please do let me know. Thank you for listening.